Hello and welcome to another edition of Health in the Heartland, a program dedicated to the health issues that affect you. I'm Karen Blakelock, and joining me this episode is Dr. Robert Karman, who is board certified in pulmonary disease and sleep medicine. Thanks for being here with us today.
Thank you for having me.
The Sleep Disorder Center of Hardin Memorial Health is actually located at 2409 Ring Road, and it has just recently moved. And so, Dr. Karman, we know that everybody needs sleep, right? And by that I mean every body, physical body, needs sleep for our health and our well-being. What actually is considered normal sleep?
Right, well thank you. Well, normal sleep is a process full of sleep rhythms and sleep cycles that is actually a normal process that helps us be our best. It helps our endocrine system, it helps our brain, it helps our heart. One of the big problems that we have is we don't get enough normal sleep, and that's called sleep deprivation. And it's now a risk factor for doing poorly and heart attacks, strokes, and kind of just poor performance. So we really want to figure out if people are having normal sleep, and if they're not, we want to fix their sleep problem.
Well, we're in the right location because the Sleep Center actually is accredited, and this is a place where they can come and find out if they actually might be at risk. So we're going to talk a little bit more about that today. Well, Dr. Karman, as an expert in the area, we know sleep is important, and generally people think they need to get about 8 hours of sleep a night. Is that the duration that we need, or what defines a good night's sleep?
Yeah, you know, a good night's sleep is different for all of us. Some of us need 7 hours, some of us need 8, some people actually need more. There's no right answer. There's just what's enough for that individual, and that's something that's kind of programmed into our brain. And that's something really hard to understand. But we do know in today's world, the most common sleep disorder that we have is sleep deprivation. And that simply means we're not getting enough deep sleep. And that results in obesity, hypertension, and now we know it's a reason why some people may actually have dementia. In normal deep sleep is where the brain clears its waste protein out of the brain, and it prevents people from getting dementia if we do that. So that sleep deprivation can really cause a lot of metabolic issues, weight issues. So we really got to find out for you what's the right amount of sleep. And it's really hard to do. Most people are working, taking care of the kids, and they short themselves on sleep because sleep's kind of a luxury for us. But sleep is truly important. And if we don't get enough, there's some really significant things that happen to us.
So you mentioned weight. Is there also a link maybe with heart disease and diabetes too?
There is. We now know that specific sleep disorders like sleep apnea, for instance, about half of the people that see a cardiologist actually have sleep apnea, and treating the sleep apnea may indeed improve their heart function, help with their heart arrhythmias, and help their heart. Untreated sleep apnea ends up with more heart attacks, strokes, arrhythmias, and obesity. There's a big link between sleep disorders and sleep deprivation and weight gain. In the recent literature in the last couple of years, we found out that people who are sleep deprived may gain as much as 2 pounds of weight a week compared to people who are not sleep deprived. And we also know that people who work nights, if they have an imbalance in their circadian rhythm, they gain weight when their body thinks it's night. They're eating, but the calories kind of put weight on. If they would be doing that during their day, part of their circadian rhythm, they don't gain the weight. So sleep is really important from a metabolic perspective with weight.
Now, when you talk about deep sleep, there's something REM. Is that right, too?
Yeah.
What is that correlation there with deep sleep and REM?
Yeah, there's a couple different levels of sleep in a normal sleep cycle. And usually we're awake, then there's a light sleep, levels 1, 2. Then it used to be levels 3 and 4 that they've now renamed as called N3 sleep, which is good. That's good deep sleep. That's delta rhythm sleep. A lot of our circadian rhythm, a lot of our endocrine function is really based on that level 3 and 4 or N3 sleep. Then there's a period of REM sleep, and that rapid eye movement is what REM means. In that sleep, there's a whole bunch of other autonomic and brain kind of function that happens in rejuvenation, and we need that in order to survive and do better. In a normal sleep cycle, we start with awake, we go through all those levels of sleep, and after deep sleep, we have a light awakening to notice, are we in pain? Is our bladder full? Is the house on fire? Is the baby crying? It's kind of built in so we notice what's in our environment. So that's one sleep cycle, but some of the reasons that people think they have insomnia is they're awake at that time and they don't think they should be awake. So it's really a normal thing to have that awakening, then go back to sleep for a normal awakening, and other people never realize that they're awake.
Let's talk about some of the definitions, because I've heard you use the term sleep apnea, and then also
Yeah.
insomnia. So let's maybe start with insomnia
Great.
first.
Great. Insomnia is really, really common. In fact, we all have insomnia from time to time, but it can be severe and really debilitating in some ways. And insomnia is probably an exaggeration of that normal mechanism for us to awaken between those sleep cycles and notice our environment. People with insomnia can typically notice it a lot than not be able to go back to sleep. But there are two types of insomnia. One is sleep onset, when we can't go to sleep, and the other is sleep maintenance. We've gone to sleep, but we keep waking up.
All right. We've been talking about the two different types of sleep insomnia, and the one was actually onset. So is that people having trouble maybe winding down from the day?
Yeah.
What are some suggestions?
Yeah, I think you're right. And a lot of the sleep onset insomnia has to do with our environment and our perception and what we're doing. In that normal sleep rhythm we were talking about, a normal natural thing that helps us go to sleep is darkness. Our normal circadian rhythm and sleep onset is really triggered by a couple things, one of which is our circadian rhythm and the other is light. So when there's darkness, our brain starts to secrete something called melatonin. Melatonin washes over our brain and it starts to kind of get us ready to go to sleep. Some of the problem is when we're trying to go to sleep now, we're brushing our teeth in front of a 200-watt light bulb. We've just been on the TV, we've been on the computer, bright light, and then we perceive, oh, I've got to turn off the lights and just go to sleep. And our brain really doesn't do that. So we really need kind of calming techniques, and a lot of it is as a sleep schedule. Our brain is something of habit, not circadian rhythm. If you go to sleep every night at 11 o'clock, your brain's in tune with that. Many times you have no trouble. But some people can't go to sleep, and then it's really important to notice, what are you doing before? Are you having some downtime? Are you relaxing? Are you staying away from bright light? Are you staying away from caffeine? So there's many things that help get us to sleep, and many things that we do actually prevent that or make it worse.
It sounds like you really need to have that routine where you're going to bed about the same time, getting up about the same time, and you hear about those people that wake up before their alarm goes off.
Right.
So, I mean, and you think, am I ever going to get there? But, you know, college kids are pulling all-nighters,
Yeah.
and, you know, we do all these things to our bodies throughout our lifetime, and then as we age, what happens to sleep?
Yeah, well, as we age, you know, sleep is an amazing natural process that we do a lot of things to disturb, but in the normal process of aging, we actually have less of some types of sleep and more of others. We have more awakenings, more sleep fragmentation as we awaken. We actually perceive that we need less sleep as we are aging. But we really don't. The problem is we just can't lay flat for 6 or 7 or 8 hours because of pain, discomfort, arthritis, having to use a bathroom. So we really have naps that make up for that. So we used to think we didn't need that sleep, but now the thought is we truly do. So what happens is there's an evolution as we are aging, and I may not need the same amount of sleep that I need when I was 24, but I need what I need, and it's different for everybody.
So you brought up a good point, napping,
Yeah.
because you know, you hear some people should nap and it's okay to take a nap.
Yeah.
When do we know age-wise that it might be okay to
Yeah.
take a nap, or is it okay anytime
Yeah.
to take a nap?
You know, when we have the urge to take a nap, I would ask one question. The question would be, are you getting enough sleep at night? If you are, then the need for a nap is probably a sign that you may have a sleep disorder. Because if you're getting 8 hours of sleep at night, it must be bad sleep if you have the need to nap. So it's really a question of why. Now, many of us have sleep deprivation. One of the ways to make up for that is by taking a nap. Or people who work nights, they've been up all day, they want to take a nap before they go to work. So a nap strategy is a great idea. A nap, typically less than 30 minutes, is what we tell people to do to recharge their batteries. But again, I'd ask that question, why are they needing the nap?
And I think you brought up some good points. Maybe we should talk at this point. And here we are, of course, in a room that's set up for people that would come in and actually go through maybe the process of being tested to see if they have a sleep disorder. So what are some of the signs and symptoms to know if I might be at risk, and when I should call the doctor to see if I am at risk for?
You know, I think fatigue and sleepiness is a big thing, but now your doctors are getting better about picking up the metabolic disorders, blood pressure, hypertension, and things. And there are some questionnaires that we'll have to put on that really helps people screen for those things. But the most common thing that people notice themselves is fatigue. I'm tired, I'm sleepy. The things I also want them to perceive, though, is their cognitive, their brain function. Many times when people have sleep deprivation, their brain isn't as sharp. They can't remember where they put the keys. Name recall is worse. They can't multitask, kind of more forgetful. And we can actually show on IQ testing isn't as good as it would be if you were fully rested. So, and one of the most other common complaints is no complaint. Many people are sleep deprived, have sleep disorders, but their perception is they're fine, they're normal. But they're usually brought here by their spouse or their family saying their sleep is horrible, they're tossing and turning all night, or they're snoring, or they stop breathing. But the patient tells us, no, I'm fine, leave me alone. I don't want any testing. So it may be completely asymptomatic to them.
So is there a typical sleep disorder patient? I mean, gender-wise, age-wise, or does it across the gamut?
You know, everyone has sleep issues. We all sleep, and we're at risk for sleep issues, whether it's sleep deprivation, whether it's insomnia. Now, as we age, there are some more serious sleep problems that we're more likely to have. The sleep apnea is one of the big ones. Sleep apnea means to stop breathing at night when you're asleep. Really has a lot to do with airway closure and throat closure. It increases when we're above 50 years old. It's more prominent in men. It's more associated if your neck circumference is more than 17 inches in men or more than 15 inches in women. It goes along with blood pressure and kind of weight gain. So there's ways to kind of look for it and screen, but it's much more common in some people. If you're related to somebody with sleep apnea, you have a 50% risk to have sleep apnea yourself because of the way we're constructed on the inside. And that construction is kind of narrow, and it makes us prone to have the throat closure at night with the sleep apnea.
Now that's serious, so tell us what actually happens in that process, and what does that put that person at risk for?
Well, with sleep apnea, it can be kind of extremes, all the way from relatively mild, which is kind of a step above snoring, all the way to severe sleep apnea. And we know that people with moderate and severe sleep apnea don't live as long. They have more heart attacks, strokes, arrhythmias, cardiac disease, and just longevity is much worse than an increased risk factor for dementia. When we have the people in that risk group, we like to kind of find them, bring them in the sleep lab or do some sleep testing to really sort out what is their severity. Do they have it or do they not have it? And then for them, their treatment may depend on their severity or kind of other factors about them. So not all treatment's the same for everyone.
But they would be an individual that would come, they'd sign in here, and they actually have the testing here. And do they go to sleep? What happens during the testing process?
Well, we have two ways to do testing. First, you need to be evaluated by your doctor and sort out which testing is best for you. And there are some medical conditions that really need to be looked at before we do testing. Things like thyroid and other things really need to be adjusted or looked at or screened. Exactly. So once you talk with your caregiver, they may refer you to one of the sleep doctors or the sleep center. Then we'll talk about what sleep test is right for you. A lot of what we do is doing sleep studies here in the lab. We get you hooked up to 16 different things, none of which really hurts, but it's just our way to look and monitor what's happening at night. And from there we can diagnose virtually every sleep disorder, at least exclude a lot of the bad ones. There's another way to test. There's home testing, which is relatively new, and you all do that here. And it's something that may be right for some individuals that we suspect relatively mild disease and otherwise quite healthy. But that'll depend on what's found out during a consultation, other medical disorders and symptoms.
So generally you're looking at maybe some lab results from lab work. It sounds like that they might have some blood work drawn to rule out some other things. If they do have the monitoring, whether it be here or at home, we're kind of looking at patterns. And saying what's happening with the sleep patterns, breathing patterns, and different things too, correct?
Right, and that's it. With sleep apnea, what we notice in particular is people typically go to sleep and their oxygen level is normal when they're awake because they're breathing just fine. As they go to sleep, their throat relaxes. And it's just all those muscles. We relax all over when we're asleep. When we're in our most relaxed phases during REM sleep is when we have the most sleep apnea. So the throat actually is narrow on when we're awake. It gets narrow when we're asleep. In deep sleep, there's no muscle tone. So the airway may actually collapse completely. And it's that collapsed airway that you cannot breathe through. So you stop breathing, the oxygen level goes low. The brain says, oh my gosh, the oxygen level is really low. I got to wake this person up. So we have this light awakening, this light arousal. Then we start breathing again, and the same thing happens all night, up and down with a low oxygen level to wake us up. Then we go back to sleep. And that may happen as much as 100 times an hour in very severe. Anything over 30 times an hour is severe sleep apnea. And then the other thing with that is that low oxygen level that some people get, and that can be an independent risk factor for not living as long. The lower that oxygen level goes, the more likely we are to have a heart attack or a stroke or not wake up.
So those individuals, and of course it depends on what happens when you go through the screening process and talking with your personal health care provider and physician when you have the testing done too. might go to the machines and the different masks and things
Correct.
that are out there too to help them
Yeah.
for the quality of life that they may need.
Yeah, and we've got a variety of treatments, and it really depends on severity and kind of patient preference as well. The best treatment is the one that we will use every night and treat our sleep apnea. So there are some things that work better in other people, but there's a whole bunch of things that we can really do to help. One of my favorite is we typically get someone's sleep apnea treated for a while. They actually lose weight, and some people, when they lose weight, lose their sleep apnea. So that's always, you know, we look for that. We try to help people reduce their weight, kind of a better lifestyle, exercise more, but really treat their sleep apnea. When we treat their sleep apnea, their metabolism goes back up to normal. They burn more calories naturally, and some of those people start to lose weight even without trying. So weight loss is a great strategy to treat sleep apnea, but you can't lose weight unless you treat your sleep apnea. So for those people, we'll use a CPAP mask or machine for a year until they lose weight. Another treatment can be what's called a mandibular advancement device, which is a dental device that some of the dentists make. It really repositions the jaw, it brings it forward enough to keep the airway open at night. And that really works well for mild disease and sometimes moderate disease. But once we get to severe disease, it can't mobilize or open up the airway enough to be an effective treatment. But it's better than nothing. Another treatment can be surgical intervention to rebuild the way we are on the inside, to get rid of tonsils and adenoids and make the airway bigger. In kids, that works great. It's our treatment of choice. In adults, surgeries don't always work. In fact, they work successfully less than half of the time. But we like to look at anatomy. We like to see if they can be fixed that way. We'd love to, you know, give them that option. Then our treatment we do a lot of here in the sleep lab is called CPAP or BiPAP, which is a continuous positive airway pressure to hold the throat open at night. It's air pressure to keep the throat open, as if you were to take a balloon and you're going to put enough air in the balloon that the walls of the balloon come apart, but not so much pressure that you're going to inflate the balloon. So it's that air pressure that keeps the throat open at night, so we keep breathing. No matter what level of sleep, the airway is open, oxygen level is great. We go to sleep, we get a normal sleep cycle, normal sleep rhythm, and we get better health.
So those individuals that would be maybe diagnosed then with sleep apnea, this is something that they're going to monitor then throughout their lifetime.
Correct, yeah. Once you have the diagnosis of sleep apnea, you may have it unless it's corrected with surgery or unless it's corrected with weight loss. Otherwise, once you have it, it typically gets worse as we age, or gets worse as we gain weight, or worse if we get other comorbid diseases like heart problems can make it actually worse, and diabetes can make it worse. It's kind of a two-way street. So once you have it, you really need to be closely monitored. You need close follow-up. You need to be readjusted. Sometimes our therapy last year is not right this year. So people are getting tired and sleepy, or they're putting weight back on because now their metabolism isn't as good.
So they may be retested depending upon what's going on, don't know, but just watched to make sure.
They need to be watched. That's one of the things we do here in the sleep lab. We typically, even when people are stable, we meet with them once a year. Our new technology on the CPAP machines allow us to understand, are people using it, but really are they using it enough? And then do we have it set on the right pressures? So we can kind of notice a lot of that and say, gosh, I think my pressure's too low. Let me readjust. So we don't always have to bring people in the lab. We can make an adjustment based on a clinical decision and what's called a smart card on their CPAP machine.
So it sounds like a true partnership. They
Oh,
have
it
to
is.
be using it on a regular basis and bringing that in and making sure that they're following
Yeah.
up with their appointments and everything is just like with any disease process.
It's a team approach, and really a lot of sleep apnea is built around kind of wellness for our body, and we want to help them treat their diabetes better. We want to help them treat their cholesterol better. We want to help them avoid their heart attacks and strokes, and really we do that by getting rid of their sleep disorders. So it's a team effort.
So sleep, as we started out, really is important for everybody.
Yeah.
Mentally and physically, we need to make sure, in all ages.
Correct.
And you had mentioned too with children with the tonsils and adults, as we age, our patterns are changing. So this is something that you definitely need to talk to your healthcare provider about and include, in your examination, sharing what you're doing with your lifestyle habits, how it's affecting you, because I think sometimes that's overlooked. Yeah, everything's, they say everything's fine. Yeah, I'm getting enough sleep. Well, what is really enough sleep?
Yes.
And diving into that conversation a little bit more with their personal healthcare provider to see if they might be at risk. And we talked again about some of the signs and symptoms. Do you want to refresh us with those?
Signs and symptoms of sleep apnea in particular can be sleepiness, fatigue, need to take a nap, but also someone who witnesses their sleep may say, oh gosh, they're snoring horribly, and they have these episodes where they stop breathing, and then they have an awakening with some coughing or choking, and then they go back to sleep in this pattern up and down. So those people, it looks like they have sleep apnea.
And I'm glad you mentioned that, because I think that's a common question that everybody has. If somebody snores, do they have sleep apnea?
Yeah, not everyone who snores has sleep apnea. In fact, not even half. And not everyone who has sleep apnea snores. In fact, we have women, most commonly, who have no snoring at all with sleep apnea. And they're either breathing or not breathing, but you cannot hear the throat closure and there's no snoring. Then we have a lot of other people who do snore, but not everyone who snores has sleep apnea. And there's a different treatment. If you don't have sleep apnea, you can see one at your nose and throat specialist to talk about snoring, but they won't consider any surgeries for that until they know that you do or do not have sleep apnea, because that will change the surgical approach.
So really looking at the whole picture,
Yeah.
what's going on in your daily habits, how you're feeling. You know,
Yeah.
do you feel like you're rested? Are you finding yourself dozing off a little bit?
Right.
Is that what you had mentioned
Yeah.
too? And the fatigue and just feeling like you don't have enough energy.
Right. Right. And then we do a lot of things in our to help in some ways, but they kind of hurt in others. Many of us use a lot of caffeine to help be more awake throughout the day. And I would again ask that question, why? Why do we need that? You know, and we want more than 5-hour energy. We want 12 and 16-hour energy. So we want to build that in a normal way. So if you're sleepy and tired, I think we should always ask the question, why? Am I getting enough sleep? If not, I need to. If I'm getting enough sleep, there may be a sleep problem. I need to talk with my doctor. Then some people sleep at the wrong time. People who work night shift, for instance, they have got a misaligned circadian rhythm, and those people both have insomnia when they go to sleep because their brain thinks it's day, and then when they're working, they think it's night. So they're really sleepy and draggy, and they're at risk for metabolic issues and poor performance and a lot of mistakes.
Now, we talked a little bit about having that routine and that schedule of going to bed maybe the same time every night. What are some other tips for us to kind of prepare for getting ready to go to bed?
Yeah, I think the first thing is to acknowledge the importance of sleep, that it's important. I'm not going to cut it short, and there's some things that can be helpful to it. And some of it is some downtime before you go to bed, at least a half hour, and we can do something boring or reading. Typically, TV is a bright light, and that the stimulation from TV actually doesn't let you secrete the melatonin, so it's not going to help you get to sleep. But we like some dim light or some soft calming music or kind of a warm bath or warm shower. Does something to change our body temperature, which kind of puts us to sleep as well. But mostly it's just that routine that works for you. Some people don't need any routine, and other people need a lot of routine. But the more routine that you have and build, if you have insomnia, the better you can handle your insomnia.
Does temperature play a part in anything too?
Yeah, sure does. One of the big factors in a better environment to sleep in is a cool environment. And some of the studies actually looked at a temperature of 67 degrees as ideal. And most people think, no, that's too cold, I can't. But it really has a lot to do with your body temperature and how things change. So a cool room, a dark room. Some people like to sleep with the TV on, but there's that photic stimulation that they may actually get their attention in those light arousals and wake them up. So a really dark room is the best advice, and then a quiet room.
We've been talking about a good sleep environment, and we said the dark room and making sure that we've kind of wound down a little bit. What about white noise?
Yeah, you know, the best thing is complete silence. Most of us don't get that in our environment. There'll be noise in the house, outside of the house. So some of us are used to a white noise, and the main thing with that, it's a low, monotonous noise. Things that make different pitches or different sounds gets our attention. So that monotonous background can cover up those other sounds that you would ordinarily hear and then awaken you. So about 5% of people who go to sleep actually use a noise machine or a fan or something to kind of give them that white noise. They feel it makes their sleep better.
But it needs to be consistent and not like an air conditioner
not
that's
the TV, not the
revving up and
yeah, and that's a very common thing. That white noise actually blocks out that other sound, so your brain doesn't get that impulse of something different, because that's what kind of awakens us with those lighter arousals. It's noticing the environment. Is the dog barking, house on fire, what's going on? There's that noise. Is it a car passing? So that it kind of covers up that noise and can be very helpful to some people.
Well, you've shared some great information with us today, and hopefully our viewers at home have had the opportunity to maybe think about some of their habits, maybe how much sleep they're getting, and prompt this conversation with their healthcare provider. We encourage you for more information to go to www.hmh.net. and visit the Sleep Disorder Center, you can call 270-706-5691 for more information also. Thank you for joining us. Dr. Karman, thank you for being here with us today, and we hope you tune in next month for another important edition of Health in the Heartland.